Well, hi everyone, it's Pete here from the Pain Toolkit, and yes, we're back again on another Pain Toolkit conversation. It's the eighth one, I believe, and we've got some usual faces that people have seen the conversations, previous conversations. We've got some new people joining us tonight, or for tonight for me, wherever you are in the planet, it may be your morning, afternoon, or whatever. So anyway, greetings and. So what I'm going to do, I'm just going to introduce myself, and then everybody's just going to go briefly around there just to introduce themselves. So I'm Pete from the Pain Toolkit, and Toby, can I start with you?
You can, Pete. Thank you. Hi, everybody. Toby and John. I'm on Camaragal land in Sydney, in Australia, and I am clinical psychologist and academic, and very pleased to be here and see you again, everybody.
Thank you. Deb, I'm going to go up to you, and then we're going to go across and then down again. All right.
Kia ora, I'm Deb, and I'm a New Zealand Aotearoa, and although I have the same last name as Bronnie, we're not related, unfortunately. I am a person who lives with pain, and I recently retrained. I'm still a teacher part-time, but I have retrained as a health coach for people with fibromyalgia and pain, chronic pain, obviously.
Thanks, Deb. And Mary?
I'm Mary. I'm from Adelaide in South Australia on Ghana land, and I am a person who's living with pain, and I do a lot of things in the pain area. In particular, we run peer support groups for and education groups for people who live with pain.
Thanks, Mary. And Susan?
Hi, everyone. I'm Susan Reid Schellinck, occupational therapist from Nanaimo, BC, Canada, the very west coast. I'm happy to be here again.
Thanks, Susan. And Jerry?
Jerry Durham from Philadelphia in the US of A. Now the cricket champions for some group. So, by the way, I automatically became a cricket fan, and I think we invented it. So I'm just going to go from there. So I've been a physio, right? We'll take it all. If all of a sudden we're good at it.
That was a new one on me, cricket.
Yeah. I mean, that's all you need to know. And I'm a physio by training. I think that's good enough.
I'm Grainne.
Hi, I'm Grainne. I'm from Norwich in the UK, and I'm a physio and pain coach supporting people with chronic pain.
Thank you. Anita?
I'm from Adelaide, Ghana country, like Mary. I have pain, and I help facilitate our group, and I talk with prospective patients at the pain unit to let them know that there's light at the end of the tunnel.
Yeah. Awesome. Okay. Thank you. Sebastian?
Hi guys, yeah, I'm Sebastian from Calgary, Alberta in Canada. I'm actually a chiropractor, and I spend half my time kind of working in private practice, half my time working in the public system. So I get to see a bit of both worlds there.
Thanks, Seb. And last but not least, Bronnie.
Kia ora tātou. I'm Bronnie Lennox Thompson, occupational therapist and researcher educator in the postgrad space, and I live with pain. Believe me, I live with pain this morning. It's hard to get out of bed.
Well, thanks everyone for introducing yourself. And during the, I don't know, I'm getting a lot of positive feedback about the conversations that we've had so far. So this is the 8th one, and they stem from doing the world, what evolved from doing the world self-management conferences, etc. to we do each February. So anyway, just let you know, we're getting some really positive feedback from a lot of people, not just in the UK but from around the world. So what's the topic this month? And I think Jerry's just owned up to it before we started hitting the record button. He may have suggested this topic, and it was having smart questions for pain self-management. So Jerry, do you want to start us off and a reason behind that thinking, or that topic?
Sure. And I think with this diverse group, I think we'll be able to start to tackle this. That's what I love about this group. I see you online. So let me give the context here. I met Pete on Twitter. I see Pete now, by the way, everywhere I am. Pete's now on Instagram, Pete's on LinkedIn. And that's perfect, because what's he talking about? Pain self-management. Here's the issue I have from my from a general side. When Pete's first started talking about that, I made up my own definition. And I didn't really know what Pete was speaking of, or actually also to. So I didn't know what he was speaking of or to. So the way I see it, there are two sides from this. And I think this came out of our last conversation really well. If a person that Anita talks to on the front end, if Anita helps someone to understand that pain self-management is part of this process, is part of their journey, she has to be able to define it in a way, right, for the context for that person. Yet if that person then shows up at the provider's office and talks about pain self-management, the provider needs to have the context. So the point here was just I think this is the perfect place to do it too, is to start this conversation. And by the way, either side, doesn't matter, that people can start to get, because we're not recording this, right? Because I still am not certain I understand what pain self-management is as a provider, as a person who believes I should support this, but I'm still not quite sure what we're talking about. So it was just about bringing context, and therefore the questions, right? What questions should the patients be asking? And yet what patients should the providers be asking in the context of serving people? So that's what it was all about, Pete. And I think this is the perfect group for it, honestly. And it really came out of last week. I started hearing a lot of different things, and I learned a lot last week. And so that's where it came out of. Now I want to make sure people understand context.
Yeah. I think,
Thanks.
Something come up. It was a lady, I think it was Fiona on Facebook, and she sent me the term self-management come up, etc. And she said that she was in London and saw someone had produced a paper about self-management, and did patients actually understand that term, the term self-management, and it sort of reminded me of about terminology, because we use it, we're using self-management all the time, self-care and looking after yourself and stuff like that. But we're using there seems to be the main thing now, what seems to be mainstream around the world, is this term self-management. The World Health Organization are using it, even I think IASP using it, and etc. Anyway, I remember years ago I was at a British Pain Society meeting up in Liverpool, and I was talking to a doctor about this. I said, like, about keeping it simple, but avoiding terms that we wouldn't pay. I call it street talk. The normal person in the street wouldn't understand. And funny enough, that previous day I've been talking. I've talked to everyone really, and I talked to one of the security guys, and just a kid. Sort of the sleeves of his coat was hanging over his fingers, and anyway, I said, yes, I pulled this kid over and I said, if I said to you to start self-managing back pain, what would you do? He said, well, I'll go and see the GP. In other words, he had no concept of what I was talking about, because back pain equals seeing the GP. So, and that reminded me, because we use these terms, self-management. I think from memory, I mean, before I went into the NHS, it was called self-care, but then it was drilled into us from the Stanford model chronic disease self-management program called self-management. That's my interpretation of it. It was to how to use the term self-management, and it sort of stemmed from there. But anyway, when I saw it, when Fiona on Facebook told me about this, I thought, well, let's find out what's going on here. So I did a poll on Twitter, or X now as they call it, and I had quite a high turnout on it, for me anyway, for normal terms, because normally I only get a few people vote. About 58 people vote, because I asked, would a patient understand the term self-management, and 58% said no. I think about 8% said yes, And the other two options were unsure and good question. And really, if you had the good question and unsure with the they know they won't, then it was, you know, the thing is, people just don't understand that term. Then I said to myself, well, let's find out if healthcare professionals understand it. I didn't get a big turnout again, but again, it was from the turnout I had, I think it was about 14 from memory. But I asked the same question: would a healthcare professional understand the term self-management? And again, it's no. So as you just said, Jerry, it's that we're missing each other, bang, you know. And this is where in healthcare, why we got this massive problem, why with all the information at our fingertips, all this research that's bombarded out on social media, etc., why the number of people living with pain is going up and it's not leveling off or going down. It's because we're missing each other somewhere along the line. And so this term self-management, it's very vague, and because I'm doing a presentation in the morning for Physio Live, and I'm going to be just briefly talking about that. And I've just Googled what does self-management mean? What does pain self-management? And I was getting loads of different variations. I mean, try it yourself. But there wasn't it doesn't seem to be one sort of description on it. So to ask smart questions, we need to be smart. We need to be start singing, as a well-known phrase, singing from the same hymn sheets, like, you know, which I don't think we are. And I I experienced it today. I had an oncology meeting, and this was our meeting. God, you know, he hadn't read my notes. He was asking me, am I still having this treatment? And I thought, well, this is it was an hour and a half late. That really, whatever. So it was just it was a telephone, the 3 month, 3 or 4 month backup thing. But I could see this ain't going to go anywhere. Like, you know, oh well, I'll ring you back later. And I said, well, hang on a minute, I'm busy. You know, blah blah blah. But and I was trying to tell him what I'm doing. He was not interested one bit, because he's so focused on treatment, like, you know. But that's okay, like, you know, they can only do what they've been taught or what's they're drilled into them, etc. So I think for me, for us to start asking smart questions, we've got to get smart. And I suppose the question I want to make, how do we incorporate this term self-management into our can we simplify it anyway? Bronnie, you got your hand up. I know you got to go, so I don't want to hold you up.
Well, yeah, no, I thought I'd get my hand up so I can have a little chat before I go, and then I'll come back tomorrow morning into it and read and watch what everybody else has said. And it just made me think when you started talking there, Pete, that there is definitely this real difference universally around the world in different cultures and different groups of people, that there is always a difference in what people hear and what you're saying and how you say it and the order you use the words in. And the most common way I used to always see this at work was with our usually our pain consultants rather than OTs or physios or psychologists, but and that's not pointing fingers of blame, it's just with training and things like that. But they would say things like, you've just got to manage this yourself, which is saying you've got to self-manage, but it's quite it could be seen as quite a negative sort of fatalistic sort of thing. Well, you just got to, you know, and that's how patients often used to take it, that self-management was seen as quite a negative end of the road thing. We've tried everything, we've tried all the treatments, you just got to manage this yourself, you've just got to live with it. And that feels quite hard, where when I'm talking about it and when I think about what it should mean and what it means to me, it feels like it means, you know, self-management means that me, the person, I have the power, I have the agency, I have the abilities, I've got it inside me to manage, to be able to deal with things. So it feels like quite an empowering and celebratory phrase. But I think depending on the order that you put those words in sometimes even, or the context in which you say them to people, it can make such a big difference, and how you do that. And I don't have the answers for that, and I'm looking forward very much to this group coming up with the answers, so that when I come back and watch tomorrow morning, it'll all have been sorted. So that'd be lovely. But yeah, that's what it means to me. To me, it's a very empowering thing. So that's what I wanted to say.
Thanks. Susan.
I love you, Grainne. That was fantastic. And I think I wanted to say, because we do tell people to self-manage, and they are told to self-manage. And I think one of the mistakes we make as clinicians is we think we have to teach people to self-manage, but they're already managing incredibly well. I mean, if they even make it into my clinic to come see me, they're managing fantastic. And so I think it's more our job to find out what's working, and certainly give them education on the nervous system, education on how it changes, and sort of functionally apply that. I like to call it functionally applied pain education, but that's me being a occupational therapist. But yeah, I think we have to really, the first thing, I've learned all my best stuff from my clients and my patients. And I think we really have to honor that and ask them, instead of us thinking we have to teach it, we have to learn from them and help them teach themselves. Yeah. Quickly, I remember I came to this, hopefully naturally, but I remember this lady came in and we made all these plans, we made SMART goals, and we did all this kind of stuff. And she comes back and she did nothing of it. I'm like, oh my gosh, this was the problem now. So we did the whole thing all over again. And after about 3 or 4 times of her not following up on the plans like I wanted her to, like the clinicians want them to, I realized what we were doing was she was teaching me about self-management skills, and I was teaching her how to create her own plans. So 4 or 5 years from now, she can then create her own plans without needing me there. So what turned very frustrating, I kind of reframed into that. And I think that's the where we should be coming from.
Thanks. Before, I know, Anita, and I saw you putting your hand up like that, but can you, there's little, I'm not sure what the button is. It the reaction one is like a little hand you click and you put your hand up. Can you? Yeah. But Jerry's just hold the spot for you, okay? So after Toby, I'll be going on to you. All right.
Yep.
So over to you, Toby.
Thanks, Pete. Yeah, it's you know, it's really interesting, as these talks always are, that we started with the question of what are the good questions, and we've immediately gone to what is this thing in the first place before we even think about the questions. And I think that's the value of this group, isn't it? Like we're kind of, you know, we're not missing anything here. I mean, it's a massive topic. I just wanted to pick up on, I think what Grainne was saying, this idea that for clinicians, I think I would agree with you 100%. We think of self-management as a thing that the patients do. It's like a binary outcome. We do the treatments, they do the self-management, and that's such a nonsense. And if we can do anything out of this, I think it would be to change that notion that there's a dualistic approach to managing pain, and as clinicians, our bit is what we do in the hospital's part, and then once there's nothing else we've given, oh, now it's over to you for self-management, which is rejecting and dismissive and utterly unhelpful, and to be fair, misses a lot of what we can do as clinicians. It's actually limiting our own ability to affect change and to be effective. So yes, before we even get into what this thing is, I would like to set the context that however we're seeing it, clinicians need to be part of it. It's just not necessarily the way they understand what their role is. And if we can broaden some minds a bit, I think we would do well.
Thanks, Toby. So, Anita.
Yeah, I think probably the key to self-management is what can I do to help myself? Not what are you going to do for me, but what can I do to help myself? And I think that's where we need people to start thinking about being able to help themselves rather than waiting for a clinician or somebody else to give them the answers. I think once you say, what can I do to help myself, you're back in the driver's seat again. And it's putting yourself back in the driver's seat from early on that makes the difference.
Thanks, Anita. Deb.
Yeah, thanks, Anita. Just leading on from that, I think as a person with pain who's a type A personality, once I knew that I could manage my pain, well, couldn't. But once I knew there was such a thing as self-management, it felt very empowering. But I also knocked it over the head with a big stick. I was trying everything and seeing it as a job. You know, I've been a person who's managed people. And so then I went on to managing myself. And so a couple of things there. One, I didn't ask for help, and I think it should be supported. And I didn't know how to get that support. And two, because I wasn't befriending my body in any way, shape, or form, I just wasn't calming my nervous system, and it was a cycle of hope and despair. So the understanding that you can self-manage with kindness, probably the first port of call, I think is somehow missing from the equation when we're told what it is. It's a list of things. Yeah.
Mary?
I think that the main problem is that no one really knows. It's not commonplace, and I don't know how we can get that message out. It's obviously sort of a bit of a public health thing. It would be wonderful to have a campaign or something like that, but I don't know that that's going to happen, because I find that people haven't got a clue. We explain it to people by saying, you know, the old story that how many hours do you spend a year with your health professionals, as opposed to how many you're on your own, and what you need to do to self-manage, and how you can get support to do that. But that's us. So I don't know the general run-of-the-mill people, and probably the majority of health professionals are not even familiar with the concept, or the fact that, you know, they don't even realise that we're any good at running support groups, do they, Anita? Some of them do. Let's not go. No, some of them do very well, and we're very well supported where we are, fortunately. But it doesn't mean that someone who wanders in with chronic pain tomorrow is not going to go down the same 2 or 3 year journey before they actually find out how they can manage like we did. So I'm not quite sure what the answer to that is. It's obviously publicity, but we don't seem to be making a lot of inroads into that.
Thanks, Mary. And Bronnie?
I was wondering, we talk about pain self-management, but how much pain are we managing, and how much is it life management and the position that we put ourselves in? So I'm speaking as a person living with pain. Part of my job as a person is to say, what can I do for me to help myself? Some of the things that I can do to help myself are to ask a clinician, what's going on here? That's part of my job. And in pain therapies, often we forget the fact that people have come on a journey to a point where they're seeing us as clinicians. There are steps and decisions that people take to seek help, and that is part of self-management. I don't know how much of my life management is changing pain, but it's about locus of control. Who's driving? And if we can help clinicians recognize that people with pain are actively making decisions when they seek help, when they ask for help, and then when they do or don't follow the advice, and then all the rest of the time that they're not in front of that clinician, that might help get the headspace right for considering what self-management is. So we were talking about what questions to ask, and I wonder if it is that who's driving this bus, who's in the driver's seat, as Pete says. And I just wanted to sort of say that with other chronic disease problems, diabetes, COPD, you know, a lot of these chronic diseases, self-management is a thing, but it's often very biomedical. And do you know what your blood sugars are doing? Have you recorded your eating patterns? You know, it's very much oriented to managing the disease. In chronic pain, I'm not sure that we're managing the disease as much as we are living our best lives in the presence of this experience.
Yeah.
And sometimes we can change that disease and sometimes we can't. So it's, yeah, messy conversation, but that's where I'm coming from.
Thanks, Bronnie. And Joey?
There's we're not even 30 minutes in. Oh my God. And I was wondering if him was going to be here. Oh my gosh. And just magically.
We've been waiting
shows
for
up.
him. We've been waiting for him.
Yeah. I mean, when we brought up the cultural thing, the first person I thought of was him and his expertise in this. I was wondering if he was going to be here. Nice to see you, him.
Good everyone. Sorry, I had to do my father duties. So
yeah, no. I think you'll enjoy the topic. You know, oh man, there's so much here. Bronnie, you know this term, and maybe everybody does. You know this term self-efficacy, Bronnie? Yeah. I think this term has been hijacked, and I refuse to use it anymore because I see providers. So I'm going to go back to the provider side of hijacking this to this separation again. And we've got to get people to this and right. And it almost gives people an out, I think. And it gives people an out to send people away. It gives people an out to call out other providers who may be extending some education and time with their patients. I don't like the word. And so back to what you're saying, Bronnie, that shared decision making, maybe that's where it needs to start. Pete, you type that in. And I thought about this is, everything I do already exists. I just try to sit in it and reflect in it and help other people, right? Whether it's that upstream stuff I talk about, managing conversations, it exists. I haven't created anything new. I've just taken what already existed and said, how can I apply it to help, people? And so this shared decision making, maybe that's probably somewhere where this needs to be planted. So I want to just go through this self-efficacy. I believe we've hijacked that word. I would love to see us lose that word into a kind of a more shared decision making. Maybe people don't see those as opposite, but that exists, the definition. And then the last thing, I think, Mary, you said, I wanted to throw something out, is Pete. I'm here because of Pete. I know this term because of Pete. I now know all of you because of Pete. So this idea of how do we get it out? I'm going to say the process has already been proven. We just have to engage it and use it. And now, by the way, where did I tell you? I saw Pete on Twitter and I learned a little bit about him. And I see him sharing his message more and more, broader and broader. And again, my world that started at Pete and my understanding of what's going on has been all because of Pete. So the impact of kind of this catalyst, I'll call Pete the catalyst on the self-management. I think, again, we have the roadmap. It's coming along. I like this idea of coming along with other people who've been on the journey, embracing them and letting them lead us down the path. So a lot of stuff in that, but I just wanted to throw all that out there.
Sebastian, I think you had your hands up next, didn't you? Where you going? There you go.
There we go. Yeah, I'm obviously very much in agreement with the shared decision making and all that. But for me, and I'm thinking about the barriers to that, and I'm thinking of today at work. Today I was working at in the public system, and I actually feel more pressures from patients in the public system to solve the problem, like you fix me, as opposed to when I'm working privately. So I had a bunch of follow-ups today and then 2 assessments, and both patients in the new assessments, by the end of it, they're basically exact words were, well, what can you do, right? So, and it's really hard. I'm just assessing, I'm not even making treatment decisions, but it's really hard. And I do empathize with GPs when you have someone who's struggling and maybe they're getting emotional in the office, and then they're saying, what can you do? And then it's hard. It's really hard to have that conversation, or maybe I just don't have enough experience with it of okay, yeah, we can try this. We can try injections. We can try, these neuropathic pain medications, but right after they've cried in your office to switch it and say, well, what can we do? How can I help you? It's tough. I'm not going to lie. I feel that pressure, and it's definitely I struggle with it, and I struggled with it twice today. Yeah. So I don't know if anyone has, like, how do we navigate, how do we turn that conversation a little bit when we have that desperate patient come to us, is what I'm curious about.
Thanks, Seb. Bronnie.
I was reflecting on the self-efficacy term, and there's a couple of other terms like that, like when I'm going to educate somebody, that irks me, because what it does is it focuses on, as a provider, I'm going to do this to you. You know, I'm going to instill this education, and then I'm going to instill the self-efficacy. I'm going to motivate you, forgetting that what's the purpose of education? It's to help the person understand. So perhaps as clinicians, one of the places we can start is thinking, what is the end result that I'm looking for in this conversation? So instead of saying I'm going to educate you, well, the end result I'm wanting is for this person to get their head around a little bit more of their pain. And then I might use education, but I might also use experiences. And similarly with self-efficacy. So self-efficacy is defined as the confidence that you can be successful at doing this thing in this particular context. Well, I can't self-efficacy somebody. That's something that they develop as a result of what I do, or the situations that I help somebody experience and what they learn through that. It's not a thing I can do. Similarly, motivation. I can't instill motivation. I can help somebody understand and develop their motivation. So I think part of it is the switch in the clinician's mindset away from the tasks that I do towards the results that I'm helping this person achieve. So that changes the nature of how I think of the person as a clinician, and also the focus on the what I am doing, because it gives me a broader range of things that I can offer that person in pursuit of helping them achieve these outcomes that we're both looking for. And that's important, because if we think about education, which is a really big component of helping people learn how to live well with their pain, you can educate in a billion different ways, lots of different ways. You can help somebody understand what's going on themselves. And I wonder if that's a big part of where we start with our health professional training, is taking the mind off the techniques and much more onto where are we going with these? What are we helping this person do? Which then takes the pressure off the therapist a lot, because instead of having to be successful, we realize that our job is to coach, to guide, to facilitate, to stand beside the person while they go through their process of discovery. And for people with pain, when they've made this active decision to come and seek help, if from the beginning we clinicians can help that person see that I'm here to listen and validate your experiences, I want to understand you, and then I want to understand what matters to you and why you are looking for the help that you're looking for, then maybe we're switching our mind away from the things that I do as a clinician and much more into what does this person want and need. And then we can explore that. And the problem with that, and I've just marked 20 assignments on pain assessment for my postgrads, and every single assignment said we don't have enough time. And that's true. And that they also sort of reflected that you can't machine learn that stuff. What people are looking for is that attention, respectful and compassionate validation. And that changes our role as clinicians from being operators to interactors, as Diane Jacobs would say. we are interactors. Can we look at that? And for people with pain, I suspect if you come into a consultation and the person immediately starts from that stance, I'm interacting with you, maybe that would switch the conversation away from what are you going to do to me to what are we going to achieve together? That's a question, isn't it? We're looking for questions about self-management. There you go. What are you going to do to help me achieve what I need, and vice? Yeah, as Deb says, that's where coaching starts. Yeah.
Jerry, before coming to you, Jerry, I was just listening to, you know, I know I've said this before in other conversations about me being a driving instructor. Listening to what Bronnie's saying, I'm saying, yeah, that was me back when I was a driving instructor back in the day. You know, I was coaching people and stuff like that. We had that rapport, etc. Katie Napton, who we all know, sent me an email this morning about a piece that's been written by a physiotherapist called Mike Stewart. And it's entitled Mirror Signal Maneuver. What can driving instructors teach physiotherapists about empowerment? And then it goes, I won't go for it because it's quite a large piece there, like, you know. And it just, to me, somehow there seems to be some sort of correlation going on here. You know, there's obviously common streams that about, as you're saying, when someone comes to see you, you know, when you're a driving instructor, someone comes to see, but they know what they know what their goal is that I'm about to get around under my own steam. And I think, but with many people with pain, we go there expecting that the healthcare professional is going to be their chauffeur, you know, that you know, when it's being taken around everywhere, like, you know. So anyway, I won't say no more words. Jerry, you had your hand up, but you've gone. You're not gonna. Okay.
I just want to. I want to throw something out there about the system, because I think I've said this a few times, right? And I think Sebastian nailed it. This is why. And then I thought Bronnie's follow-up kind of pulled together. How about this? How about the clinician isn't the clinician? I just look at it as a funnel, by the way. So, and the only reason the clinician's up here is because I call it top of funnel. That implies nothing about anything. It's the first stop. So bear with me on this. So someone comes in, and I want to take what Bronnie said. Someone comes in to see Sebastian, and Sebastian knows his focus here is to manage his patient, just like Bronnie said. But then Sebastian is focused on the result. Treatment, service, the thing, because the patient says, what are you going to do for me, basically? What about this? And this is what I learned from Pete, and I've learned from a lot of people here. What about if Sebastian knew these health navigators? I think I've heard you guys use these terms, and I think they exist in other countries. Yeah. And they're finally starting to get some traction here in the States. These aren't clinicians. These are people that understand the journey. I love this word journey, maybe experiences, but I love this journey, right? This person sitting in front of Sebastian is on a journey. And so I always think about what's the next step for this patient. So if Sebastian knows he has a resource pool of people who have experienced the same thing as this person sitting across from him, and hopefully is somewhat culturally wise aligned. So, right, we can put that in there too. Then Sebastian goes, Jerry, I have a solution for you. And then it's to meet with Pete. And once they get past Pete's accent and they can finally understand him, Pete's going to help him a lot. But rather than, and I don't think you implied this, Bronnie, I'm just taking this to the next step. Rather than imply the clinician then has to do the next step, you didn't imply this. That the next step, God forbid, and I'm sure I've said this here before, we lose our egos a little bit, and the actual next best step is for this person sitting across from Sebastian to meet Pete. Why Pete? Pete's been on this journey. Well, what's Pete do? He's a driving instructor. Who the F cares? Almost cursed. Who cares what Pete does? He's been on the journey. He has the experience. Pete can actually probably do more work in this at this time than any clinician can. So that's all I wanted to put that out there. And again, we've got the cultural parts, and But to me, this is rather than change this whole behemoth, it's $3 trillion and getting closer to 4. I'll let you guys plug that into your calculators with the 13 zeros behind it.
Yeah.
But trying to figure out the clinician part and this system part, no, I'd send, by the way, if I knew Pete and someone came to me with pain, I'd be like, you know, I got a solution for you. And then I'd call Pete and say, Pete, and I'd probably pay him for his time. And I'd say, Pete, do me a favor, get on the phone. And Pete would make more progress than I would in 15 minutes than I probably would in an hour. So it's right. I think there is this leverage here that we have with the people that aren't clinicians to, I'm going to say it, to solve some of these problems, or let's just say there are solutions to this. All right. I know I overran. I'm going to be quiet for.
I'm going to hand over to Toby, but 28 years ago, next month, Toby was my driving instructor. Because he was one of the guys on the pain management program, and him and his colleagues guided me, you know, to sit in front of you guys, having a really groovy time in life, you know.
Mm-hmm.
Sorry, Toby.
I
want to say that before, but God, 28 years ago next month, mate.
Nuts, isn't it?
You still don't look any different. I've got to be honest with you.
It's that baby face.
Do you know, but like it is, it's not, so many things in it. These are probably these conversations. There's so many things spark off, don't they? We'll have to, anyway, I wanted to really endorse what Sebastian was saying about that dilemma, because we're preaching to the choir a bit in our group here, aren't we? And that's such a tough one when we're seeing somebody who hasn't had the fortune to be exposed to the way that we understand, and back to, I think it was Anita's point about a public health campaign, you know, because you see it so often, and people they just don't see pain the way we know it. It's most helpful to see it, and they don't see pain as I think Bronnie mentioned, you know, sort of chronic disease like diabetes. Imagine somebody going to the diabetes doctor and saying, right, what can you do to fix my diabetes? And being really disappointed that they don't have a solution for them right there and then. It's just, you know, there's such a need to try and educate the public about this in many cases, but not everyone. But I just want to pick up on the driving analogy is that I also think part of the problem is that we think of, clinicians often think of if it is this, my job is to drive you to a destination and drop you off. And because you're good now, you've done your pain program, you've had your 10 sessions or whatever it is, and you're done. I've given you all, you know, all the techniques and all the, and that's you done. And as Jerry's saying, this is a journey, and often a journey of life. It's not something that you can just say, okay, well, you've got everything you need to know, and my role's finished. And that's also not necessarily what patients want to hear. They want to hear that there's something you can do for me, to me, at me, and I'm done. And so there's such a lot of accommodating perspectives and understandings, and I think, you know, for a lot of folks to come to a first consultation, you know, it's a jarring experience to hear that I don't have a solution, and, you know, tell me about your sort of broader self. I don't want to tell you about my broader self. I want you to tell me what tablets do I take to make this better, you know, and so going off on that journey is not a journey I'm ready to go on yet. And you know, I think it's really important to acknowledge that can be just as invalidating for people as we want it to be validating, you know, because if it's not meeting them where they're at that point. So there's so much to this, and we're not going to fix it in one consultation. Although, interesting, Bronnie, I was thinking when your students are saying, oh, I don't have enough time, I kind of, it's true, but it's also, you know, you can do a lot in 10 minutes, can't you? You know, especially if people's expectations are pretty low generally, because they've seen a lot of other health professionals who, like Pete's experience with the oncologist, are pretty dismissive and pretty, you know, not person-centered in any way. 10 minutes of really good person-centered care can be worth a fair bit. 2 hours of crappy care is anyway. So I think, yeah, there's so much to all of this, but you know, kind of remembering all the time that we are the people who we're talking about, and often possibly, unfortunately, probably the people who will look at this with lived experience. Maybe we'll find people who are searching for something different, but there's a lot of work to do, clinical side and public side, to get us all on the same page in the way that other chronic diseases do much better. And yeah, there's reasons for that too, but yeah, thanks.
Mary, did you have your hand up before Bronnie? I'm not sure. Well, you go, Mary. Go on. I thought I saw you had your hand up. I'm not
Uh,
sure. Go on.
Maybe we're about the same. I'm not sure. But Hem asked, how do we make peer support an integral part of pain care? And look, I just couldn't agree more. I think that when people have finished their time in a pain clinic or whoever they may be with, then they can become very lost. They're sort of out there on their own again, and sometimes that can be difficult. But if you have somewhere else to go, then there's that step. The problem we have one of our pain clinics is right into this. We are being recommended left, right, and centre. There are signs in the waiting room as big as you can see it. It is everywhere. Everyone is told to come to us. How many people come? Hardly any. We work with the ones we've got. They enjoy it. They think it's wonderful to have, to have that relationship with others, and they're not alone anymore. But I don't know what the answer to that is. I do know that there is a chap here in Adelaide who is researching that very thing. He's about to do a PhD on it. So what he'll come up with will be very interesting. But just getting people to understand that that there is no magic fix is difficult, really hard. I know, I've been there. I was looking for that for 2 or 3 years. And I don't know, it's very difficult to overcome that. But once you can get past that, we have a lady who was right back there, wasn't she, Anita, who's we hope will join us on Tuesday. And she is just gradually realising that she can actually do something and starting to do something. And it's been awesome for us to actually see that. So there is that. If we can, I think there again, it's getting the word out, and pain clinics and health professionals sending people to peer support groups, but there are not enough peer support groups. So that's yet another thing. So I won't waffle any longer.
Thanks, Mary. Bronnie?
So the journey meaning that people are not always ready for everything, but they might be ready for one thing. That's really cool, as long as they can circle back and come back for more when they are ready for those bits. And in the tertiary program in Christchurch, it used to be that it was one shot and done. So you come to the program and then you're discharged. And then the complaint was, but people are being recycled through this thing, and it's creating a backlog, and what can we do about this? And well, the fact is that we're not all ready for everything at once, and that learning what you can do for yourself is a process, it's a journey, and people are ready for different things at different times, which means listening really hard to the person and which part of the self-management thing they're wanting. Second point, one of the obstacles to peer support that I've encountered just this week is when we know that there's somebody who has successfully managed their pain, and we know somebody is struggling, and how do we connect them given privacy concerns? This is from clinicians. How can I share this person's details when they're both patients, and am I breaching privacy? Given that in New Zealand we don't have funded peer support, and I don't think from our legislative perspective, I don't think that's going to happen, because there need to be regulations around the people who offer this kind of support. They're not regulated professionals, because that's the safeguarding everybody. And similarly with pain coaches. So those are some things that are kind of obstacles to offering the peer support. Where possible, I think it would be lovely to have funding. We don't have that. So this is where the efforts that individuals who are willing to be peer supports and peer coaches can, be visible, so that we can actually say, hey, there's people out here who can help, and here's where you can go to. So some of those support groups, yay, and Hem's just saying we're working on some cool ideas about this. Yes, please, because self-help is I've always found group work wonderful in pain management, because in a group, other people with pain know what it's like, and they will push and nudge and challenge each other so much more than I can do as a clinician. I have a bit more face validity because there I have this, I have pain myself. But when people learn from each other, it's so much more powerful and experiential. And so I keep coming back to peer self-management in groups. And I know that Toby and I are working on a project around this that is hearing from people with pain. How can we go about doing this? How can we learn from one another rather than being told this is what self-management is? Maybe we need to define it as people with pain and then be able to pick up the bits that we need at the time that we need them, and not have to feel like we can read the book, absorb it, do it, and go off and be wonderful ever after, because life changes.
Thanks, Bronnie. Deb?
I almost lost the point of what I was going to say there. I've been listening so hard and it's been so interesting. As someone who has pain and also coaches people with pain, they often come to me when they're really desperate and they have tried everything else and the fixes have not worked, but they're not necessarily ready to accept it. And so I think what Toby was saying was really, really interesting, and the people after him. But circling back to that smart questions thing, is that's where they come to it, and not on the same timeline by any means. But it's really nice to be able to look back over the time that I've worked with them and go, well, this is where they were here. And smart questions from me and from themselves about what they're doing and why they're doing it. At some point, the penny drops. I don't even use the A word because, you're not ready for it necessarily, but it is possible. And so before I knew what the topic was for today, I knew what the topic was, but I didn't exactly know how it was going to play out. I thought about the smart questions thing. And I think if somehow we can encourage ourselves as people with pain and as clinicians to get people to ask their own smart questions. Like when I wake up in the morning, I ask myself, what can I do today? And that comes from both angles. It's what can I manage and be really honest with myself about that, but also what can I productively add to making myself feel better? And that balance between doing that, being that person that just thrashed it and not thrashing it anymore, somehow gets me through. I hope that's made sense. Anyway, that's me.
Thanks, Deb. Seb, I saw your hand up a minute ago.
Yeah, I kind of forgot what I was saying too, and then I kind of just remembered it again. So, I think I might have mentioned this in the past or two, but one thing is, like myself, I don't really, I don't have persistent pain, so I could be like the smartest pain neuroscientist in the world. I could know like everything about how the brain like interacts with the spinal cord, which interacts with but at the end of the day, I don't have chronic pain, right? So there's a huge element that I'll always be missing as a clinician, and admittedly, it's something I'm self-conscious about, because it's the lived experience is such a huge part of their life, and I don't have that, and peer supports do have that, and I think it would, like for me, just the thought of knowing as a clinician without pain that I could either co-run a group or direct people to someone doing well with pain almost feels like a weight off my shoulders in a way, because I can't possibly pretend I have that experience. I can't fake it. I can learn from other patients, absolutely, and I have learned from other patients. I've learned a ton, but at the end of the day, I still can't say what it's like to wake up consistently and have pain the second I wake up, and a lot of clinicians can't say that, which is tough in a way, I think.
Thanks, Seb. But just before I forget, I think did you say about Health Navigator? Yeah, in New Zealand, isn't there an organisation called Health Navigator?
They've just changed their name.
Oh.
But yeah, Health Navigator is a website of self-management resources across all chronic diseases in New Zealand. They've just changed their name. Pete, your material's been on there for years. It's been wonderful. It's so good. I was going to say that the
What's the new name of it?
let's hope I haven't.
What's the new name of it now?
Oh, I can't remember. Somebody Google it quick.
Hepuna Vayora.
What?
That's it. Yeah.
I'll put that in the link, Pete.
Oh,
It's
yeah, well done. Thank you.
Thanks, Hem. I was just pointing out that as a person and a clinician living with pain, my pain's not the same as anybody else's pain. So I'm not sure that knowing what it's like to live with pain is as much of an advantage as you might assume, because my pain's my pain, and it's not, I don't think my pain's the same as Deb's and Mary's and Anita's, and you know, that's the weird thing about pain, that even though there are some things that help me with my pain, they don't fit for other people, and I wouldn't want them to. What I've had as a clinician is lots of exposure to lots of people with lots of different kinds of pains who've come up with a whole bunch of different ways to find wiggle room, which is my way of saying, let's, you know, self-management. Let's find wiggle room so you can do the things that matter in your life. Because, and as in my knowledge and experience of seeing lots of people try lots of different ways and stuff, I've got more that I can offer somebody to say, who's stuck, to say, you know, some people have found this really helpful in your situation. Let's experiment with that. Let's try it out and see how it fits with you. And that is my go-to when it comes to self-management and, or any part of pain really, but self-management is, I don't know how this is going to land. I wonder if you could give this a go and let's see how it would fit into your life, to allow you to have a chance to suck it and see, if you like, do you like the flavor of that one? And that also allows the person the choice of how did it fit for them, which takes me as a clinician away from, I've given you the solution, now how come you're not using it, damn it? And for the person, it's acknowledging, as a clinician, I'm acknowledging to them, I don't know how this is going to work for you. So there's this kind of humility that's needed. And for the person with pain to be curious, are they willing to experiment and have a go at this, not knowing what the answer is, but seeing how it lands? Because I really see my journey with pain, which is now quite a few years, has been this process of experimenting, because the way that I managed when I was young is not the way that I manage today. The activities that I do to manage when I was younger are not the activities, so it doesn't look the same. So it's they function in the same way, but I'm not going to do some of the activities that I used to do to help me manage in terms of, say, movement practices. They've changed form over the years. My integration of things like mindfulness has changed over the years. And I might find mindfulness really helpful, but other people find it absolutely sucky. So can we experiment with that so that that person can feel what that feels like? So one of the questions we could ask on both sides might be, I wonder how this might work. I wonder, because if we are curious and we're not certain and we are wanting to see how this fits for the person, then on both sides, we have to wonder. Curiosity, it's a wonderful thing.
Thanks, Bronnie. Yeah, curiosity, it keeps coming up all the time, quite frequently of late, you know, the being curious and stuff like that. What I was going to say was, I mean, as Jerry points out, you know, I mean, I'm learning so much stuff. Like, you know, you think you know you've got a handle on stuff, and then someone comes along and sort of flips it a bit, thinking, you see it in a different light, you know, and For me, I think, you know, they, like in recent years, like we're going back to that term self-management. I don't know I first heard it, I think from Keith Melcham, where they said they put that word supported in front of it first, supported self-management. But I mean, if it works, it works, like, you know, but it just seems to be so challenging how we do it. Can I ask it? I put it in the chat. I know you're working on that project. Is it launched yet? Like, you know, this our recovery. Is that still going? Is that about to? Have you launched it already, Toby and Bronnie? Or
not? No, it's going to launch June next year. The platform will become available. So we're just building it at the moment. Bronnie and Hem and I and a team of lived experience folks are building it. But it's actually really, I'm sure you guys are thinking the same, Hem and Bronnie, like hearing everybody's endorsement of the need for a place where people can go. And as I noticed, somebody in the chat mentioned about sort of support group is a bit of a kind of an off-putting term for a lot of people, and you know, for whatever reason they've experienced of that, and often sort of online support groups and things are places where people have, I mean, I guess partly because they have an opportunity to offload out, you know, the no one's shutting them up, so their experience is a valid experience, but it not always wonderful for everybody else to be part of hearing all that. So yeah, so this the format of our recovery is going to be a place for people to and it actually has come up a lot today. So fun enough, it's going to be about listening, as much as it is about, and you know, talking about clinicians, you know, we're trained to talk and do stuff, as opposed to trained to ask questions. And you know, asking the right question is what makes the penny drop, doesn't it? Not giving information, it's asking the right question. And so hopefully it'll be an opportunity for people to listen. I mean, yes, it'll be an opportunity for people to share as well, because that's a big part of this, of course, but it's going to be carefully moderated so that it isn't an opportunity for people to dominate, I guess, is ultimately what it is. You know, it's not about invalidating people's experiences. It's about equity. And you know, if there's 10 people in a group, 10 people need equal opportunity to be able to share their experience. But yes, the emphasis is much more on self-reflection and listening than on downloading, although that's a need as well, obviously. So yeah, we're super excited about this. Yeah, great team.
Will people outside of New Zealand and Australia, would they be able to log on and be members, or
eventually? So the trial, so it's running. We're doing it as a proper randomized trial to see whether it adds value to people's usual care initially, and once we get through the trial and we confirm that it has an evidence base to it, it's valuable, then yes, in theory it opens up. Well, I mean, in theory, because of time zones and things, you'd want to have one of these in all jurisdictions so that everyone has an opportunity. But it's a model, and just for those who don't, it's a model based on the 12-step Alcoholics Anonymous meeting model, where people have an opportunity to come anytime, any place. Because the other thing that we've sort of missed in this conversation is, you know, people have different flare-ups, crises with their pain at all times of the day and night and the weekend and the holidays and whatever. And, you know, our system is not set up to help that. And so having a place where you can access care when you need it, and then not when you don't, I think that's part of the flexibility of the 12-step model, and that's something we're going to build into this as well.
Thanks for sharing that. And sorry, Em, to keep you waiting.
No, I think as Toby said, yeah, it is an exciting another 3 year sort of journey. So watch this space. And again, that sort of leads into the previous comment about what Bronnie was saying, curiosity, right? Like again, I was thinking about like what is this about asking smart questions to facilitate pain self-management conversations. I was thinking, I just want to sort of share a recent experience. I was interviewed for a qualitative study. So the study's aim is to look at what are physiotherapists' understanding of self-management support? So I think they might have done some Google searching to see who in New Zealand has done sort of self-management work, and then probably have sort of invited to talk about it. And the student has actually interviewed. So this is finally a physio student. She's doing it for her honors project, and sorry. So the student was the last sort of the candidate, I think, in terms of interview. So maybe the 12th or 10th. And she was saying, I asked her, like, after the interview, I asked her, like, okay, so what have you, what are some things that you picked up from listening to all these sort of different physiotherapists' understanding of self-management support? She actually said, it's all about sorry,
Bring your
Tim, I
little
think
bring your little and honest, just away.
She was saying it's all about listening and creating a safe space for my clients, and how can we journey together to in terms of where they want to go. And I asked her, okay, so does it sort of reinforce what you've learned in your degree, or what do you think? And she said, I really wish I'd done this project in my second year or third year. And I really wish learning about qualitative research in my degree. I really wish my my fellow students had also had the opportunity to do this qualitative interview, because it gave her the opportunity to listen to people's experiences. B, the curiosity to understand more. I think that's the whole point about qualitative, is about how to facilitate divergent thinking, more ideas about a phenomenon or a concept. So if you translate that to asking smart questions in a clinical context, exactly the same. I really want to understand this person's life and where they are, and pain and the context. And I don't even need to fix anything. I really want to understand, and I can actually figure out lots of strengths from what they've said, and I really need to sort of reflect it back. I don't even have to ask questions. Even power of silence is an important question in pain self-management conversations. So, and then again, another similar story, I had an anesthesia registrar. So he has to do a little research project. So he came, and then we planned like a project around clinicians, like pain specialists and GPs, experiences of tapering opioids with their patients. Oh, geez, like we thought like it's not going to be an emotional, like I was thinking, I was telling him, like specialists, they are very succinct, precise. So I think we may have like 20 minutes, half an hour we might have done with each interview. Turns out each interview was about more than an hour and a half. So people are very emotional, saying that. I think was Sebastian who was saying, like GPs especially, like they are 15-minute consult, patient on long-term opioids, escalating dose, pain becoming worse and worse, so not helping them. It's not about, it's more about like not helpful in that context. And then there was pretty much less options in terms of what they have to do. And this registrar who did this project, he said, hey, we were not trained to do any of this. Our questioning is deductive, diagnostic. So we are looking to find the diagnosis. So by ruling out everything else. So the questioning is a narrowing divergent style, not a convergent style, not a divergent style. So for him, qualitative just changed his whole world. So he goes and presents about how to do qualitative research. In any of the conferences he's asked to talk about the research that he's done, he actually doesn't speak about the research. He talks about qualitative research, how to do it. Because the medical fraternity sometimes, again, pretty much everywhere, like numbers are easy, fancy, and it's got a different sort of positioning in the research realm. whereas not words, emotions, interactions, relationality, it's got it's kind of termed as fluffy. So it's again coming back to that sort of asking questions. How do we train us to, yeah, again, I feel like I'm biased qualitative researcher. So it's comes back to that, really. So I'm easy to sit with a question or a couple of questions open-ended and just sit with that. And the more the person speaks, the better the interview is, the deeper the data is. So for me, I think as a clinician, I find it so much easier to not to ask any question really, like even ask a broad open-ended question and leave it there. So I don't know, I'll stop there, but I have a few things to say about peer support. But one thing that we have done is we did a trial, an online pain management program, iSelf-Help. So now this program is actually run by a peer support person and a clinician together. So it's fascinating to see how it's evolved, and Deb would know, like Natalie, who's the peer support person, and so she's trained somebody else, Julian, and then she's also training somebody else. So it's kind of like it's fascinating to see how much she puts into each of the sessions, and also learning some tips and tricks. The sort of the examples she gives, the real life examples. Again, like somebody, I think it was Jerry, who said, like, like we just have to let go of our egos and just zoom out to see who are we working for. It is the person with pain. So if that means I have to work with like a lived experience expert, yes, yeah, I would love to work with someone, because we are actually helping somebody else who is in our service, and that's the whole purpose, and that's why we're all here. So I think sometimes our professional silos or our systemic silos can restrict or determine what we do. But if you just zoom out and see who all these systems and professions are designed for, that's what I always come back to. Yeah, I'll stop
Our
there.
intention is to help the person, but our siloing tends to focus on what we do as clinicians rather than who's the best person at the right time doing the right things or helping the person in the right way for that person to achieve what they want to and need to achieve. So that's the person-centeredness part of person-centered care. And I think if we look at person-centered care, that's when we are coming to the supported self-management aspect. Because if we're really focusing as clinicians on the person and what they're looking for, wouldn't that mean that we're available to support them and we're hearing what they're asking for? We're not assuming that we are working with that person to find out if their pain wasn't such a problem, what would they be doing? Which has been my driving question for such a long time. So two things. One is that when we're looking at, they're called soft skills for clinicians, this communication stuff. It's really hard work. If these are soft, fluffy skills, then why do people like Toby, whose living is being made on talk therapy and talking, why is that so elevated? But these inside other clinicians, these are considered soft and fluffy skills. That seems to be, doesn't quite work for me. And so they're not often valued. They're very difficult when I've been trying to run courses, very difficult to get people to attend them, because what people, clinicians, are looking for is a technique rather than the process of open ended questions and even the process of guided discovery in experiential learning, where we help somebody learn, they do a movement and we guide them to say, what does this feel like for you? How's that fit for you? Those are not things that we are taught in undergraduate training in particular. And then it's hard to find courses that actually teach you to do this. It's hard to run courses because they're not very popular. And yet that's the supported part that as clinicians we need to offer, is though asking those questions, being open and curious about them, and then asking ourselves, you know, what, when somebody isn't taking the message on, which is something I've heard from clinicians say about patients, oh, this person hasn't taken on board this message, asking ourselves, I wonder why, I wonder how come, what's got in the way of this person finding that to be a truth for them. So that puts more effort on me as a clinician to understand rather than just assume. End of rant.
Thanks, Bronnie. Susan.
Yeah, I'd love to, we started this off by wondering what self-management is. I'd love to maybe, if we could sort of figure out what it is, like, what do we think it is? What does it look like? Can we define this? Can we, make it make a bit more sense? Anyone have a good definition of self-management?
Mine is all the things that I do to help me live my life my way in the presence of my pain and my other things that go on in my life. And that includes asking for help and taking pills, actually. And like, I'm having an x-ray on Monday for my hip. That's self-management because I've asked for it and I want to be able to make the decisions about what I do from there. It's in the stance that I take. So it's everything that I do to help myself live my own life my way in the presence of my pain. That's my answer.
For me, it's keeping myself in the driving seat.
Yeah.
You know,
which is a much more abbreviated version of what I said, Pete.
that's me, self-management, you know. So I think just keep it simple. When I see things on social media by healthcare professionals, I do get a bit not frustrated. I get thinking, why are they complicating this stuff so much? Like, you know, and we're paying, you know, such a, yeah, sure, you know, that's their thing, like with the pain patient, etc. But pain it affects us in so many other ways, like, you know, with our heads, you know, low mood, etc., sleep problems, relationship worries, etc., or problems, work problems. You know, it's like that, you know, the pebble going into like a bowl of water or something, you know, that cascades out, you know, and all those ripples are, you know, pain sort of, that is like the bit that, you know, the pebble hits the water, but all the other stuff that sort of cascades out from there, you know, and so, you know, and I always think, oh, I learned a little phrase years ago, is not about self-management, well, about self-management, it's well, I'm going to tune into self-management. Self-management is a simple program for complicated people. And it's about it, really. And go back to the listening business, someone else pointed out to me years ago, the fact that we got two of these and just one of them, you know, it gives it away from the get-go, like, you know, so, you know, we've got two of these, so this is why we need to listen more, you know, and what's the old saying, learn to listen, listen to learn, you know, so listening business seems to be the way to go, but but the fact of like in healthcare at the moment, I think the factors, so many factors going on with lack of this and lack of that. I only learned tonight on social media as a GP ripping into the Prime Minister. Why is there? Why there's 2,500 GPs unemployed, and yet people go and get an appointment. You know, you're thinking, well, what's going on here? Am I going a bit bonkers here or something? You know. So healthcare seems to be sort of going through a bit of a topsy-turvy sort of thing. But to me, I sort of keep saying, well, you know, we've got all these long waiting lists. Well, why can't we promoting the self-management message? You know, but they can't be if you can't teach what you don't know. you know, because that medical model is still the king. The, you know, medication is still less expensive than having to sit and talk to someone, like, you know. So it's a long old road we're on, etc. But we will get there. Mary, did you have your hand up? I know Toby just put your hand up. Mary, did you?
Oh, I did, and I went down. I put it up again. I was just going to say very briefly what you said about things being basic and being easy. We try that. People who have pain don't have a lot of extra reserve to get into sort of terribly complex things. So the more basic the management can be, the easier it is, and it is easy to do that. And we just keep it very basic but evidence-based, and find that works best. We've even simplified goals right down to being quite simple, and we do find that works very well for us. We've had some really good success with that.
Thanks, Mary. And Toby, and then I think we'll start winding up, winding the conversation up. So Toby, over to you.
Thank you. I just want to pick up on Susan's sort of point about, like, how do we define self-management? And like there's whole literature on this, actually. There's a lot of people who've looked at this question, and there's all sorts of different responses. But something I learned today was from Deb, actually, about saying that the term self-management, if I understand Deb correctly, made you feel like it's like a pressure to push yourself, and for you that your sense of what that term meant was an unrelenting standard, and you must never kind of give up, and that really struck home to me that everyone brings their own lens to all these terms and all these different things, and so we've got to be so careful, I guess. As you know, catastrophizing's been around, you know, that's had an enormous sort of backlash from lived experience of people, but even something you think might be relatively benign isn't to some people, depending on. So maybe it's, I don't know, supported self-management maybe offsets that a bit. I do like supported self-management because it brings that idea that the support's got to come from somewhere. It isn't just, right, you've done your journey, you're good to go, see you later, never seen again. But yeah, with an awareness that it's gonna resonate differently with people, and I'm not sure there will be a one sort of term that works for everybody. But it's always good to learn. Thanks, Toby. So can we just go around the group and just sort of say what's your take-home message from today's conversation? What are you going to think about for the rest of the day, or while you're having a sleep, or, you know, in your dreams and whatnot? For me, it's the take-home message really is the last bit. I was just sort of listening. I think sometimes when we're having a conversation with someone, we want to jump in before they've finished. While you're listening, but you're not really listening, because you're getting ready for your reply, because as they stop talking, bang, you're in there. You know, so to me, it's to do a bit more thinking before replying. I think that's what I'm going to go away with tonight.
Pete, can I just follow you, because I actually looked up listening, the definition of listening, while we were talking, because I thought, this is a really good thing, because listening comes first for me. And I've written down, make an effort to hear something. So make that effort. Give one's attention to something, and be alert and be ready to hear. So that readiness, that's probably what I'll take away from both sides.
Anyone else?
But I'm going to take away the public health message. It's really reminded me that we're just not good at, and still not good at changing community ideas and changing clinics. So I'm actually going to go to my public health colleagues. I had this little note to myself, give them an assignment on, like, so if you had to change thinking about chronic pain, give it to the third year, because I think that's, public level will do better than individually. So that's my take. Change the story about this.
Thanks. Who else?
Totally agree with that, Toby.
Hen?
Yeah, just gonna reflect by finishing from today's conversation on pain is political. But I saw someone on Twitter sharing about Jackie Willimby's other panel's talk from the British Pain Society ASM. So pain is socio-political, and yesterday in the pain management program, the first session, we talked about pain, the impact on mood, impact on activity, impact on social. Someone said, "Hey, can you add money?"
Yeah.
Because pain can make someone change jobs or do the job differently. That means they are more likely to go, I mean, financially, they are disadvantaged, and pain is expensive because more investigations, more specialists, public system, I go private system, you know, that sort of search that Mary was talking about, like everyone goes through that journey. So pain is an expensive long-term health condition. So the social stressors, again, the current New Zealand government looks at people who are on benefits as someone who are or you know, like not useful contributors for the society and the system. So which again adds, that was another patient who said to me, like, "Hey, I'm a political person. I don't want these things stress me out." So again, yeah, taking a public health approach, taking even wider social political conversations about pain. How can we do it? What am I doing in my sphere of influence is what I'm asking, and I'll be thinking about tonight, Pete.
Okay, thanks very much. Anyone else before we go?
Yep.
Oh, sorry, Bronnie. Sorry, yeah.
That's okay.
I've got
So my summary is that as each one of us is individual and unique, and our lifestyles are individual and unique, and as clinicians we are individual and unique, it's unlikely that we'll come up with one definition and one set of skills and one thing. That it is about finding wiggle room to get out of the finger trap, and everybody does it a different way. So perhaps it is that shift in mindset of what we do together to help me live my life.
Okay, Bronnie, thank you very much. Anyone else before we go? Oh, sorry, Seb, I've got sorry up there.
Yeah,
sorry, mate.
I'd say my two takeaways. I always come into these conversations very selfishly, in that I think I only ever ask questions and I don't answer anything. But for me, I think for me the two things are just in terms of I always like when I can find little nuggets of like very clear like catchphrases almost or something like that. And Pete, when you were saying kind of like as a clinician, right, like the perspective of saying to the patient, like, I can be your driving instructor or I can be your chauffeur, right? Like that's just so clear. Like, yeah, you can learn to drive yourself, or I'll just, do you really want to rely on me forever, kind of thing. So I think that's fantastic. And then the second thing, more like broadly, is what Bronnie said, just how I was kind of feeling, I feel that sense of self-consciousness of I don't have pain, it's harder for me. Why would someone listen to me? Like almost every day I have a patient and they're just like, so you're young, your spine is so good. And I'm just like, just the, like, everyone's pain is different. So I don't need to be so self-conscious about that, because one person in pain can't necessarily say they have had even a close experience to someone else in pain. So, that I can have a bit more confidence just taking what I've learned from all the patients I've seen and helping throw around ideas and things like that. So I appreciate you saying all that, Bronnie.
My pleasure.
Thanks, Seb. Anyone else? Okay.
Go on, Deb. You normally have something to say, Deb.
I did. I said the listening thing. Actually, wrote down listening comes first, which so that's
I think
what I'm
everybody's
taking.
eager to go. So, well, thanks very much. Has anyone got a last? Sorry, I don't want to. Has someone got something to say? No. Okay. Thanks everybody for joining us tonight. I hope everybody's watching or listening to this recording, this conversation. Is found it useful. I don't know, every time I do one of these things, I always come away with a lot more sort of winding myself, like, you know, because for pain wear you down a little bit. So well, I'll send everybody a recording. It'll probably be maybe Sunday now, because I've got to do some stuff tomorrow. So anyway, thanks everybody for joining us. If you're watching, listening, be kind to one another. Pain management or pain support yourself management works, but you got to work at it. All right. Take care, everyone. See you now. Bye.
Thanks, Pete. Thanks, everyone.